We are live.
Okay. So, good evening, everyone. I welcome you all to the fifth International Ophthalmic Conclave, where we will have a global platform for all the ophthalmic professionals organized by the leaders of All India Ophthalmological Society. Over the next 36 hours, we'll be taking you towards 360 degrees around the world on a comprehensive journey in learning a plethora of topics, including advancements, innovations, all the techniques and updates and the best practices across the globe from the esteemed faculty all around the world will be giving us different perspectives and learnings. So we welcome you all and we thank you all for this journey. And let's hope that these 36 hours are a good learning for all of us. So we look forward to this session, which is a Young Innovators Forum by the YOSI, which is Young Ophthalmological Society of India. And this will be headed by Dr. Devakant Mishra, who's a young dynamic president of Young Ophthalmological Society. Then Dr. Nilesh, who's the secretary of YOSI, and this will be moderated by Dr. Prasanna, who's a very uh, you know intelligent and innovator. We have been seeing him since long years, and he's a glaucoma surgeon practicing in Chennai. Our panelists include Dr. Aditya Sethi, who is the treasurer of UC, Dr. Ashraful Haq, who's from joining us from Bangladesh, Dr. Karan Bhatia, who is the vice president of Young Ophthalmological Society, Dr. Kendrick Koshi, Dr. Sonal Kalia, who's the ex-president and the governing council member of Young Ophthalmological Society. I'm Dr. Gunjan, who's coordinating this session. I'll hand over this session to Dr. Prasanna for moderating. So, Dr. Prasanna, uh, are we ready for the session?
Yes, Dr. Gunjan. Thank you, Dr. Gunjan, for the sweet introduction. So, we are here today for the AOS International Ophthalmic Conclave, the fifth edition of it, and it's going to be for the next 2 days, 36 hours around the globe in 36 hours for the next 2 days. So, the YOSI, Young Ophthalmology Society of India, are very grateful for this Young Innovator Forum given to us by our parent society, AOS. So, we welcome you all, and this is a short introduction of each of the speakers and the panel who are part of today's event. So first, welcome our president, Dr. Devakant Mishra, sir, uh, who is also the president of YOSI and the member YO Standing Committee and member International Committee of Vitrio Buckle Society. Nilesh Kumar, our secretary, and he's also the inventor of Dix Pro. They both will be chairing the session for today, the Young Ophthalmological Society of India's Innovator session. Next would be myself. I'm the joint secretary of this organization, followed by our coordinator, Dr. Gunjan Budiraja, who's a cataract and cornea specialist and a refractive senior consultant, and also part of our UC team, followed by the panel involving our treasurer, Dr. Aditya Sethi, and joining us all the way from Bangladesh, welcome Dr. Ashraf, the founding president, scientific secretary of Bangladesh Society of Cataract and Refractive Surgeons, and many more awards and accolades to his credit, one being the best YO award winner at 36th APAO Congress 2021. Welcome you, sir, from Bangladesh. We also have our dynamic Vice President, Dr. Karan Bhatia, who's also being in the panel for today. And he's also won the AOS IJO Silver Award for his innovations, especially mixing technique, where a new technique of scleral fixated IOL, for which it has won numerous awards and has also well published in PubMed Journal. Following from Hong Kong, we are joined by Dr. Kendrick Shi, who's also a very active council member of APAO, Asia Pacific Trauma Society, College of Ophthalmologists of Hong Kong, and also the editorial board member in the APJO. Welcome, Dr. Kendrick. Thank you for joining us all the way from Hong Kong. Followed by another panel, Dr. Sonal Kalia, ma'am, our immediate past president, also a very dynamic member of Rajasthan Ophthalmic Society and Jaipur Ophthalmic Society. Welcome you, ma'am, for this session. Followed by allied panel of speakers. We have a mix of Indians as well as people from Australia, one naming Dr. Christopher Go. Thank you, Chris, for taking your time and being here, who's also very active in the APAO platform, as you can see, along with the young ophthalmologist grant winner of the Malaysian joint meeting, which happened last year. Welcome, Chris. I also like to welcome Dr. Karthik, another innovator who has innovated the U tool, which he'll be sharing it today for his congenital glaucoma, and he's also part of the YOSI team and another dynamic executive member, followed by Dr. Mia Wat Iso from Burma, a medical retina fellow, who's going to talk on her innovations in the field of retinal investigations. Welcome, Dr. Mia. And we have Dr. Zain Khatib, a dynamic refractive surgeon, also part of the executive team and a management committee member of BOA and Journal Club committee member who has numerous publications and has won awards in ASCRS for his innovations, which he's going to share in the next few minutes. Welcome, Zain. And also we welcome Dr. Duong D. Huong from Vietnam, who's also another innovator, who's a speaker in various Asia Pacific platforms and a member of the Vietnam Ophthalmic Association. So we also have the last but not the least, the sixth speaker of the day, Dr. Samir, who's going to share about his innovations on flipped classroom teaching. So without much delay, welcome all the chairperson, speakers, and the panel. And I would like to hand over the session to our chairperson, Dr. Divakant Mishra, sir, the president of YOSI, to have a few words and welcome everyone before we start the session. Over to you, sir.
Thank you so much, Dr. Prasanna. And at the outset, I would like to thank AIOS, especially Dr. Santosh Hunawar, sir, for making YOSI part of this wonderful program. And he has allowed us to be the opening batsmen for this great program, and we are happy to participate in this. A special shout out to Dr. Prasanna for curating this program in, I think, a couple of hours. So, and thank you, Gunjan, for taking out time, moderating, and all the other speakers whom Dr. Prasanna has just introduced. So look forward to the session. And it is a very important aspect of ophthalmology for us, the innovations part. And as young ophthalmologists, I feel all of us should be very interested in this. And we have a wonderful panel and speakers from which we can learn a lot today. So over to you, Dr. Prasanna. Look
Yes.
forward to the session. Yeah.
Thank you. Thank you, sir. So without much delay, we are moving into the first speaker of the day, Dr. Christopher Go from Australia, on novel updates on secondary IOL, a shot at the second chance. Chris, you are good to go.
Thank you, Prasanna. So I'm just going to quickly give an update about secondary IOLs, about the different options and what are some of the experiences I've gained from my different fellowships and what I do now. So regards to secondary IOL, there are multiple indications. The most common that we probably encounter are probably surgical complications like a PC rupture, and other things are things like trauma or connective tissue disorder like Marfan syndrome, and more recently opacified IOL that requires IO exchange. In terms of the options, essentially, it depends on whether they have any capsular support left. So whether there's presence of capsular support that will allow you to do a sulcus IOL or some sort of a capsular segment versus if there's an absence of capsular support requiring other options. And if there is an absence of capsular support, then it would be anterior chamber versus posterior chamber. And then there's also sutureless versus sutured options as well. So this is a table outlining some of the options, comparing anterior chamber versus posterior chamber, sutureless versus sutured. And the highlighted areas are essentially the areas where I'm going to talk about. So essentially all the ones that have an absence of capsular support. So things such as anterior chamber IOL, iris clawed IOL, Yamane options, Calavale, and sclerofixated with suture as well. So anterior chamber IOL. So the video on the right is showing what one of my demonstrations of anterior chamber IOL insertion is one of the earliest IOL suitable for absence of capsular support. Requires a large corneal wound or scleral tunnel more recently. It's probably the quickest and the easiest to learn, can be performed the easiest with poor corneal clarity, unlike some of the others that I'm going to go through later on. Good thing about this is that complete PPV is not required. And it's great for patients who are not available to return to operating theatre or unavailable to tolerate long operating time. So maybe elderlies who are not able to lie still on the back for a long time, or patients who are from far away in the rural areas. Some of the tips to think about are essentially PI is required to reduce the risk of papillary blocks. There's a risk of the corneal edema and UGG and glaucoma due to its proximity to the cornea. In terms of tips to think about, mainly is thinking about the orientation of the IOL. So because it's not the usual reverse S-shape IOL that we use, my advice is check the IOL packaging, and that will give you a good idea of how to orientate the IOL and for the vaulting of the IOL. And make sure you put in some pilocarpine or myocol afterwards, before the IOL insertion, and they'll give you a better access to the iris for the support of the IOL. So next up is our iris clawed IOL. In here in the video on the right, I'm demonstrating a iris clawed IOL that's done retropapillarily. Having said that, you can also put that in the anterior chamber instead. Has a similar profile to side effect profile to anterior chamber IOL in that it can cause some corneal edema. Some argue that it might be less corneal edema as it's further away from the endothelium. But having said that, I don't think that's always true. Can be placed in the anterior chamber or posterior chamber, as I mentioned. In this case, you can see I'm putting it posteriorly, going behind the iris and unclaving that behind the iris. Because it requires healthy iris tissue, it may not be suitable for everybody. It still requires a large corneal wound like anterior chamber IOL, maybe slightly smaller, but still requires quite a large wound. Side effects or issues with it is that it requires specific equipment. So it requires a specific a specific IOL forceps, and also enclaving equipment if you're putting anterior chamber. You might get a small and irregular pupil post-operatively, and that comes with experience on where you're going to enclave the IOL to the iris. Things to think about, if you're putting it retropapillarily, you have to flip the iris up to the IOL upside down so that it's vaulting the same direction, and make sure you use the specialized equipment like I mentioned, as you can see in the video, where it's a duck beak sort of forceps to hold the IOL so that it doesn't slip away and it holds it a little bit better. Then we move on to scleral sutured IOL, one of the earliest way of sort of scleral fixation, described in 1997. And since then, there's been multiple different techniques described using multiple different points of fixation. So most commonly 2 or 4 points fixation, different sutures. So whether that's Prolene or Gore-Tex suture, and different externalization or knots burial. So some people use trocar, some people just bury it into the sclera. Here I'm demonstrating using Hoffman pockets to bury the knots. Good thing about it is that you might be able to better center the IOL because you're able to adjust the tension as you're suturing them in. Possibly less inflammation because there's less iris touch, and also requires a full vitrectomy. But because it is requiring posterior fixation, it requires a full vitrectomy and more intraocular manipulation, and you can run into suture-related complications. Things to sort of do, I would recommend, are maintain an anterior chamber with a low infusion pressure, try to bury your knot. So that's whether using Hoffman pockets or using a sclerostomy to bury your knot so that you don't run into as much suture-related complications, and slip knots to adjust the tension requirement as you're centering the IOL. Then we move on to probably one of the more commonly used techniques nowadays for the younger surgeons, which is the Yamane technique. described by Yamane himself in 2017, and there's been many modifications since then. It is an off-label use of 3-piece IOL, but the good thing about that is that it's readily available to most of us, given that we have stock available for sulcus fixation. It is a smaller gauge sclerostomies compared to other techniques, meaning that you have less dissections, you have less opening of conjunctiva and no sutures required. The risks are, because it is a 2-point fixation, you might have a risk of IOL tilt, and that can also come about with uneven scleral tunnel, especially for the early adopters. Also, because it is using a 3-piece IOL, you risk bending or kinking the IOL optic, which could then again lead to IOL tilt. Tips to think about: put the main wound to the left, and that will help with docking of the haptic. And also use IOL that are more pliable haptic material. So like a size CT Lucia 202, which is made of PVDF haptic, versus a PMMA haptic like a ZA9003 or MA60AC. And then finally, coming to Calavale, which is a more recent development with a specialized IOL with a T-shaped plug haptic. And that allows you basically to externalize that into a sclera. It's specifically made for scleral fixation. Because it's less likely to get tilt because of the T-shaped haptic. It has a steeper learning curve. There's a higher cost because it is a specific IOL made for these specific purposes. The current version has quite a fragile T-shaped plug. And so it does have a higher learning curve to try and make sure you don't break the haptic and do other things when you're externalizing the haptic. So the tips and tricks, basically, I would say place it above the iris before you externalize it, because that will give you better access to the IOL. And hold the haptic optic junction in parallel to minimize breakage, as you can see in the video earlier. So take-home message, master one of the ACI or iris clip IOL, because they are the easiest to learn when you have a complicated phacos, and it's the quickest to do and only requires anterior core vitrectomy. It's the least the surgical view required and probably allow you to do that there and then in one procedure. Having said that, the other procedures possibly has less complications because it is further away from the cornea. So you're less likely to corneal edema and glaucoma. Good thing to know is that there's no method proven to be superior compared to the other, and they all have similar complication rates, but just different in terms of the complications. So I think the selection is based on patient factors, the facility factors like what's available and the equipment's available, and pre-op counseling is the most important, because some of these are probably more likely to run into complications in other areas, and repeat surgeries and longer recoveries are things that you have to counsel patients about. And that's it. Thank you.
Thank you, Dr. Chris, for taking time all the way from Australia to share your novel techniques in the secondary IOLs. A quick comment from Dr. Ashraf, sir. Sir, your comments or any questions to Dr. Chris regarding his.
Yeah, thank you. Thank you, Dr. Prasanna and YOSI friends, for inviting with such a lovely session. And I'm really honored to be here with you. And Dr. Chris is an excellent presentation on the secondary IOL. So the AC IOL and the scleral fixation IOL. So right now we are not actually want to use the anterior AC IOL or iris claw lens. We are going to the Yamani technique, where this brings us a very good result. Though your point is right, there is no superior technique. It depends on the surgeon. It depends on the eyes. And for the young ophthalmologists who are here, I must say that proper vitrectomy and the marking of the fixation is very important before going for the scleral fixation or Yamani technique. But I have one question that for the iris claw lens, many of us have the question that we get the question that after the iris claw lens, if the patient need retinal laser or the patient need the full dilatation exam, so is that cause any atrophy or problem to the iris?
I think with long term, yes, there is definitely iris atrophy and things like that. So they're less likely to get a full dilation following an iris clawed IOL. Having said that, with indentation and with other things, if they truly need a vitrectomy, I haven't had any issues with that. And so it's slightly more difficult, but that can be same for other IOLs like a pinhole IOL and things like that. And I think that I found it much more difficult doing a pinhole IOL like an IC8 IOL compared to a iris clawed IOL. So it is more difficult, but I don't think it precludes you or makes it sort of a contraindication to not putting one of these because of those factors.
Thank you very much. It was an excellent presentation. Thank you.
Thank you, Chris, once again. We'll move on to the second speaker of the day. I would request all the speakers to join for a photograph at the end and also for the discussion for the other presentations as well. So with that, we'll move to the second speaker of the day, Dr. Karthikeyan Mahalingam, again, executive member of YOSI, to talk on his innovation on congenital glaucoma, how the innovative view tool for preoperative assessment made a difference. Over to you, Dr. Karthik.
Thank you, Prasanna. I first thank AOS and YOSI for giving me this opportunity. I'm going to talk about a novel U tool which you use to measure corneal diameter in infants which are screened for congenital glaucoma. As we know, corneal enlargement is an important indicator both for diagnosis and monitoring the prognosis of disease in congenital glaucoma. Usually, castrovisual caliper is being routinely used for measuring corneal diameter, but it needs examination and anesthesia or sedation. A few years back, when I was doing my residency in Dr. Rajendra Prasad Center for Ophthalmic Sciences, AIIMS, New Delhi, myself and my friend Dr. Rahul were measuring the corneal diameter for the kid with congenital glaucoma during examination under anesthesia using this castrovisual caliper. Then we thought, why not? As we thought, corneal diameter is very important indicator for diagnosis and prognosis of the disease. Why can't we measure in the OPD basis? If it was an adult, we could have tried a slit lamp or IOL master or lensar to measure the corneal diameter. As it was a kid, it is difficult to use those things which need a sitting position, or we can't directly keep a caliper on a child who won't be cooperate unless we sedate the child. So we were thinking, what can be done? Next, we got this idea. We devised using a three strimmer strips, we devised this U-shaped tool. We thought while using these readings, we'll measure the corneal diameter. And we compared it with the castrovisual caliper and validated the U tool for measuring corneal diameter. First, infants presenting to the congenital glaucoma clinic posted for UA were recruited. Before the examination and anesthesia, in the OPD basis, corneal diameter were measured using the U tool. During examination and anesthesia, along with the routine examination, the corneal diameter were measured using castrovisual caliper. Later, the corneal diameter obtained from both the techniques were compared. See, in OPD basis, in a cooperative child, see, you can see U tool is just placed above the orbital rim. If the child is not cooperative, when the child is sleeping, we'll ask the patient to come bring the child without giving any food. After coming to the OPD, we'll ask them to feed and ask them to sleep. After sleeping, we will gently open the lids and using the U tool we will place. U tool will ask the attender to gently retract the lids, and U tool was placed over the orbital rim and measured. Then photo is taken using the smartphone. While taking the photo, we have to take care that the U tool, the head of the patient, and the phone, all three are parallel to each other to avoid the parallax error. See, here I'm saying it is kept. After taking photo, then we'll draw a rectangular frame from the limbus of the cornea towards the U tool arms. This is using the image editing software. Using the image editing software, we'll draw this rectangular frame and we'll measure the corneal diameter. This reading, here we can see the images where first util is placed over the orbital rim and the rectangular frame is drawn in both in normal patient, in glaucoma patient who are awake, or this is the awake patient, this is the sleeping patient, which we retracted the lid and measured. As we do not place the util directly on the corneal limbus to measure the corneal diameter, a correction factor must be added for the minification cost to the distance between the util and the limbus. The distance between the corneal limbus and the util was measured in multiple patients, and approximately it came out to be 16 millimeter. For the 16 millimeter distance, the correction factor was deduced to be 1.15 mm. So the corneal diameter was calculated by multiplying the reading which we got to util into with the correction factor, that is 1.15. The mean age of infants which we assessed were 6.7 months. Most of the patients had primary congenital glaucoma. Next common diagnosis was anterior segmented dysgenesis. See, this shows the box and whisker plot of comparison of corneal diameter using the util, using the util and the Castro-Vizek caliper. See here, the first chart is the corrected value of the util, which is almost similar. The util value and the Castro-Vizek caliper value was similar. This second graph, by mistake, if we don't apply the correction factor, the difference between the Castro-Vizek caliper and the corneal diameter measured using the util without applying the correction factor, it was approximately 1.5 millimeter. So if you don't apply the correction factor, the util reading showed a 1.5 millimeter less compared to the Castro-Vizek caliper. This is the Bland-Almond plot showing the 95% limit of agreement. It was a narrow limit of agreement showing a good agreement between the two techniques with a difference of 0.1 millimeter between the two techniques. Here is the scatter plot. The corneal diameter measured with both instruments has a good correlation with a peer-set correlation coefficient of 0.95. Here we have some limitations. Like measurement error could occur if the util or the phone are not placed parallel to the eye while taking photograph. As I showed in the video, the util and the phone has to be kept parallel to each other to avoid the parallax error while measuring. Then some patient, around 50 to 60% of patient we are able to take in the awake state. Around 20 to 30% while sleeping we retracted the lid and measured the util reading. Some patient, 18% of the patient need either sedation or anesthesia for measuring the corneal diameter. So another thing is all the patients with congenital glaucoma has stretched limbus. There could be variation in measurement of corneal diameter by different observers. To conclude, this is a novel innovation which provides a no-touch technique of measuring the corneal diameter. We are not touching the limbus or cornea to measure the corneal diameter. So while considering a difference of plus or minus 0.5 millimeter within the acceptable range, 72% of the readings were acceptable of the util readings were compared to Castro-Vizek caliper. And it provides a corneal diameter measurement in awake or sleeping state without the use of anesthesia in majority of the cases. That is 82% of cases we were able to measure without the use of sedatives and anesthesia. Hence, it can be used for screening pediatric glaucoma by first contact physicians, mostly the pediatricians or the gynecologists after the delivery, or by the optometrist or ophthalmologist, especially when the UA is delayed. Thank you.
Thank you, Dr. Karthik. So we have a very elite pediatric ophthalmologist among us, our treasurer, Dr. Aditya Sethi. Aditya, your comments on, pediatric and glaucoma, you're going hand in hand with the both of it. So your quick comments on this innovation by Dr. Karthik.
So I think Prasanna and Karthik, great job. This is something that really requires a lot of thought because a lot of these, I'm sure Prasanna also sees it, a lot of these cases get delayed by the time they come to the doctor. And we don't know how much new data, like you said, non-ophthalmologists can also do it, pediatricians can do it when on birth. So a lot of data can be collected and we can actually maybe have a better idea how to treat them even with this data in the future. Who knows, maybe an early treatment or maybe awareness can go hand in hand because once you give them an extra tool to do, maybe they'll direct these patients much earlier than they would have otherwise as well. So I think great innovation and minimal use of, I'm sure, the expenditure. And I think this is sometimes the simplest ideas are the most effective ideas. So kudos to you. Well done. And of course, we're looking at more data from you, and hopefully this gets published soon, and we have more scientific data to fall back on. Great.
Thank you, Dr. Aditya. So to keep time in mind, and we'll also take up discussion at the end. We have a 15-minute discussion at the end. We are just having a minute delay now, so I think we'll go to the next speaker. So without much delay, Dr. Mia Watsoi from Burma.
Hello, everyone.
Hi.
It's nice to see you again, guys.
Thank you, Mia. So would like you to talk us and take us through us on OCTA, the new kid on the block for retinal disorders. So thank you, Mia, for consenting, and please do share your valuable inputs on the same. Over to you.
Okay. Today I would like to share my experience about OCTA. OCTA has emerged as a non-invasive technique for imaging the microvasculature of the retina and choroid. It uses the intrinsic motion contracts to detect flow through the different segments of the eyes and does not require the injection of the contrast agent. Like in the case in FFA ICG, so it can avoid. It allows for the routine use to detect disease and monitor the treatment efficacy. OCTA, but the OCTA does not detect dye leakage or staining, and the recognition of the abnormal vessel like retinal and choroidal vessel. Main advantages are the shorter acquisition time, and it is a non-invasive process. And it provides a quantitative analysis of the retinal vessel. OCTA is performed with difficulty in cases like corneal opacity or edema, lens opacity, hazy vitreous, vitreous hemorrhage. But the image can be analyzed, quantified, safe compared with the findings of the later examination. OCTA is useful in vascular occlusion, diabetic retinopathy, pre-retinal neovascular proliferation, subretinal macular new vessels, vascular malformations, angiomatosis, general acquired and congenital retinopathies, and it can detect even in glaucoma and optic disorder. But currently, OCTA does not provide useful information in uveitis and choroiditis. OCTA quantitative parameters can measure the flow area, non-flow area, and vessel density MEG. In contrast to the two-dimensional conventional angiogram, technology provides a 3D imaging information of the macula and visualize the peripapillary capillaries that supply the retina nerve fiber layers. There are some limitations and artifacts which are important to consider in the interpretation. But currently, 4 main commercially available OCTA devices, Zeiss, Angioplex, Octoview, Topcom, and Hyderabad Engineering. OCTA artifacts can be related to the image acquisition and processing, ocular movements, eye anatomy features, operator errors, and display strategies. This photo shows the retina exudated artifacts. When interpretation of the OCTA, it's always look out for the normal retinal vasculature. The scans are usually performed at the posterior pole, size for the time being 3x3, 6x6, 8x8, 12x12 section. The reading of the OCTA must be made into two steps. Firstly, analytic step like the following features must be examined in sequence: localizing the scan depth, flow and decorrelation, vascular morphology and architecture, texture, followed by the synthesis and diagnosis step. In analytic step, localizing the scan depth by 4 main steps during the revolve phase, always look for the superficial vascular plexus, deep vascular plexus, RPE, Bruch membrane, and choroid. And this is the normal OCTA showing the 3x3 two-dimensional end-phase image report. And in figure A, show the superficial capillary plexus, B show the deep capillary plexus, C is choroidal capillaries, and D is choroid. When interpretation of OCTA, we must always look for the fovea avascular zone, FAZ, normally about 500 micrometer. The geometric center of the FAZ is taken to be the center of the macula, and it is a point of fixation. And it also indicates the prognosis of patient in most of the retinal disorder. In flow and decoration, OCTA is generated by motion contracts, so the blood flow can be rapid or slow, direction can be transverse or vertical, the vessels can be thin or thick. In vascular morphology and architecture, the architecture of the vascular network may be regular, irregular, it may be dense, sparse, dilated, faint, dense, and tangled. The meshes may be sharp, distant, or indistant. The network may be loose, dilated, narrow, faint, dense, compact, tangled, sharp, or indistant. Also need to assess the shape of the vessels that may be regular or irregular, and the density of the capillaries that may be sparse or dense. And also look out for the texture, which is based on the vascular density. So it can be loose, coarse, fine, thin, and grayish. This is a photo with the diabetic patients without retinopathy. In FAZ, in diabetic patients without retinopathy, OCTA shows the FAZ area is larger than in normal, healthy individuals. The size of the sun capillaries increases, some are thicker while others are close, and we see the looser network with larger and sparse mesh. There is an increase in size of the fovea avascular area. This is early signs that appears before the onset of the microaneurysm, and at this stage, the condition is still reversible. These photos show the retinal vascular diseases. If photo A show the branch retinal vein occlusion with the capillary draw-out area. In the area of the occluded vein, it is the infratemporal area. Photo B show the BRBO with the collaterals, which is located at the supratemporal area. In PTR with MVE, extensive capillary non-perfusion is at the macular and the retinal periphery. So wide field OCTA may provide the peripheral non-perfusion area and MVE in this case. This is a photo showing the OCTA of the patient with the PTR and advanced neovascularization of the disc, which show as the yellow asterisk and temporal retina gray asterisk. So the segmentation at the level of the vitreoretinal interface, it shows a tortuous pre-retinal vasculature. CMV, it is recommended to study both the superficial and deep vascular plexus, even if they seem to be normal, and also RPE and basement membrane. In AMD cases, CMV usually are located below the RPE, which is type 1, and above RPE in subretinal space, which is type 2. As a main boundary, we will choose the basement membrane because its profile follows the ideal posterior pole cavity and is crossed by the CMV. This is a type 1 CMB. So you can see the vascular network below the brush membrane. This is a type 2 CMB. You can see the vascular proliferation proliferate from the choroid into the subretinal space. It breaks the brush membrane. This is a type 3 CMB. You can see the vascular connection between the choroid and the intraretinal space. It is the end of my presentation. Thank you.
Thank you, Dr. Mia, for this wonderful coverage of OCTA.
Yes.
Panel, any comments or anything that you want to add on Dr. Mia's OCTA? So as the panel are just coming up with their questions, Dr. Mia, I just wanted to add few points on OCTA in glaucoma as well. It is one of the upcoming devices or ocular investigations even in glaucoma, because we are talking about the mechanical theory, especially the vascular theory as well. So the vascular theory, the vessel density is lower or seem to be lower in glaucomatous eyes. So that is where OCTA, comes into play a lot of role, and especially post glaucoma surgery as well. This really helps us in understanding the disease per se. Even in iritis, we have images of OCTA in iritis, bleb filtration, an avascular bleb can be imaged with this, and it's more of the vessel density and the microvascular vessel density that has become a real game changer with OCTA as to what I would like to believe. What are your opinion, Mia, on these factors of microvascular dropouts, MVD, or the vessel density that we tend to see in glaucoma as well, but we are more focused on the areas such as peripapillary VD. Whereas, what is your impression on parafoveal or perifoveal vessel density and your take on it? Dr. Mia, you're there? You're on mute, Dr. Mia.
Okay.
I mean, my question was, what was your take on the parafoveal vessel density dropouts or perifoveal vessel density that drops out in ischemic phenomenon? Because papers are coming out that beyond retinopathy and glaucoma, even radiation optic neuropathy, compressive optic neuropathy, optic disc bruising, or even multiple sclerosis or AION. Any of your experience that you would want to share on beyond retinopathy and glaucoma, what is the spectrum of OCTA?
Actually, I don't have a much experience about glaucoma and AI1. I only have an experience on the retinal diseases. Sorry. Yeah.
Okay,
I think if I can add a comment,
Yes, sir.
great presentation. I think what really is mind blowing for me with OCTA is the wide field OCTA, which is coming up, which has been there now, where we can look at the peripheral retina and look at the vasculature there and actually study that, because that will open a new Pandora's box. So as an innovation, I think it's a great innovation and great, good highlighting everything. And a lot of new things can come up and a lot of new ways of treating disease early can come up because of this new way of looking at it. And of course, the artifacts and everything go down with OCTA being high resolution imaging now.
Thank you, Mia. Thank you, Aditya. So we'll move
Thank you,
on.
Prasanna. Yeah.
Thank you, Mia. Thank you for taking time. Be there for the photograph at the end. So with that, we'll move to the fourth speaker of the day, Dr. Zain Khatib, who is going to share his experience and journey on how he self-built his innovation software, which for refractive surgery. Over to you, Zain, for the enlightening innovation that you did and which won the AACRS Best Innovation Award in that category in 2023. Over to you.
Thank you. Thank you, Dr. Prasanna, and thanks for inviting me to speak in this esteemed YOSI innovative session. So you basically, made me go and relive those days of when I was making my refractive surgery software. I'd kind of forgotten about it. I was just using it, but I just, when I had to make this presentation, I just went through some of the things I had gone through to make it. So I'll just be sharing, small glimpse of my journey, why I wanted to make a refractive surgery software. Okay, so any innovation actually starts off with a problem statement. Yeah. So in my case, my problem statement was astigmatism management and refractive surgery. So for me, I used to see good results most of the times, but in some patients, I would get these annoying cylinders post-operatively, which were not explainable by anything. So I used to wonder, why am I getting a post-operative cylindrical refractive surprise? Like, I've done a very good refraction, I've checked everything pre-op, and why do these surprises in cylinder come? And I did a little more digging, and I realized that there is something called as ocular residual astigmatism. So when the cylinder that the patient manifests on the trial frame is not matching with the corneal cylinder, the anterior corneal cylinder, you get a vector difference between the two called ORA, or ocular residual astigmatism. And there's a lot of research work and papers now which say that any patient who has a higher ORA has a higher risk of getting a post-op residual cylinder. And then there are different papers which tell you, how to go about, tackling this. So for me at that time, everyone had told me that, you should go in for doing contour LASIK or topography guided LASIK. At that time, I used to not do it. So I thought, okay, let me try topography guided LASIK. People were like, this is the best for doing high cylinder corrections and all. I bought the software, I started doing it. So, if you see this refraction, this patient has a minus 1.75 at 90 degrees. But what is coming from the anterior cornea is minus 0.4 at 2 degrees, which is not matching with the refractive cylinder. And to my surprise, Alcon told me that Contura is not suitable for these patients where the topography cylinder is high, is different from the manifest cylinder, where the ORA is very high. So my whole purpose of using Contura LASIK was to get better results in these patients. But when the company said that this software is not meant for this, I was a bit disheartened. I did a little more research and found out that there's something developed by Dr. Kenalopoulos called topography modified refraction, where instead of treating the cylinder coming from the manifest, you actually treat the cylinder coming from the anterior corneal topography. And the rationale for this was that the higher order aberrations are what contribute to the difference between the two. So in topography guided LASIK, we are treating higher order aberrations. That's why we have to kind of treat the manifest cylinder, and we have to treat the topography cylinder and not the manifest cylinder. So I started doing it like this, and I realized that my inaccuracy in treatment was not improving. It was still the same, or in fact, it was becoming worse in some cases. So this was not the solution. I realized that there had to be something else. Again, I did a little more research and I found that Dr. Mark Lobanoff has made a software called the Forcities Analytical Engine, on which roughly my software is also based. I'll just come to what exactly this software does. But the point is that when I tried to purchase this software, it was not available for sale outside of the United States. What this software does, I'll explain to you. But then I thought that I have to do something like this on my own, and I'll give you a glimpse of how, of what exactly my software is doing. So if you see this refraction, this is -8 with -1.75 at 60. So -1.75 at 60 is the manifest cylinder. Now this cylinder is coming from different components of the eye. Okay, so 0.79 at 31 is coming from the anterior cornea, lower order cylinder. These higher order aberrations, so this is the aberration profile of higher orders, which comes from the software itself, from the Contura software. This is also contributing some amount of cylinder, which is also coming from the anterior cornea. Then there is cylinder coming from the posterior cornea, and there is cylinder coming from the lens. So there are four factors which contribute to the manifest astigmatism. Now, simple mathematics, we know what is the manifest astigmatism. We know the cylinder coming from anterior cornea. These are provided to us. Okay, we can also know the cylinder coming from the posterior cornea from a Scheimpflug device. So we have two variables. Now, these higher order aberration cylinders, if we can find out the cylinder coming from here, then we'll have only one variable left. And if we make a mathematical equation, we can find out how much of cylinder is coming from the lens or from inside the eye. So the first step was to be able to understand how much cylinder is coming from this higher order aberrations. So each patient has a unique higher order aberration profile pattern like this, and we have to find out how much cylinder is coming from here. So I made some, mathematical and geometric calculations based on where these purple zones in this area. You can see these purple zones are called as talises, and they are at specific angles. So if I can find out at what angle and what is the size of these, I try to make a nomogram which could predict how much astigmatism is coming from the total higher order aberrations. So in my software, you have to feed in like this, the angle at each of these purple zones are what is the color zone and horizontal axis, so horizontal side. All this is provided by my software, and I created my software. So just to explain to you, this is how my software looks like. So if you see, it's a Excel-based software. So we go into the contour planning here, and then we have to feed in some of the details. We have to feed in this Talis data. We have to choose what posterior corneal astigmatism we want to use and press proceed. And then the software will tell you the astigmatism coming from all the individual components, from the cornea, from the higher order aberrations, from the internal. And then it will tell you what is the manifest refraction and what is the final modified refraction to treat. Okay, so it looks very easy, but it was not easy to make it. So if you see the raw images of my Excel sheet, it's got a lot of formulae involved. So you just look at the formula. There's a lot of trigonometry. There's a lot of maths, geometry involved, and that is how I came up with this thing. And then I went ahead making the software. So I don't want to go into details, but I'll just give you a example to show what my software does. So this is 36-year-old female. This is her refraction. If we see the right eye, we can see that the corneal cylinder is very different from the cylinder from the manifest refraction, and so is it for the left eye. Okay, so then we feed in the data in our software. Then the software will tell us how much of astigmatism is coming from the individual components. And in this case, you can see there's a lot of astigmatism coming from inside the eye. More than one is quite high. So we cannot treat this patient with the complete cylinder they have. So finally, my software recommended in the right eye, instead of 1.75, you have to treat only -1. In the left eye, instead of 1.75, you have to treat only 0.75. And the software was also designed to take care of nomograms and things like that. So this is how the software modifies. And this particular patient, post-op day 15, she was 6/5 in each eye, extremely happy. And just to show you that the software actually works, you see the auto refractometer reading, the cylinder is close to 0, in spite of not correcting the cylinder that we had initially. So if you would have corrected the 1.75, the patient would have probably got overcorrected. So that is where my software comes in these sort of odd eyes, where we are going to get a refractive surprise. It will prevent us from getting by doing the proper, mathematical modification required. So that is about it. I just wanted to share part of my journey. And in 2023, I won the award at ASCRS for this software that I developed. And I've also published the results of my software, and they were very promising. That is why now I use the software for almost all my cases. So thank you for the opportunity once again.
Thank you, Zain. We have Dr. Ashraf, Dr. Gunjan, for your comments on this wonderful software, not only innovated, but it's also come to the market as well. So your comments, Dr. Ashraf, Dr. Gunjan, your comments?
Yeah. So, Dr. Zain, it's a very genius innovation that you have done, and it's actually very, very practical because these kind of refractions come up very, very commonly in our clinics, and really we have a lot of refractive surprise in such. So, have you got it patented yet, this software? Because you should do that. And one question I wanted to ask Dr. Zain, what is the highest astigmatism you have tried with this software to clear in these kind of patients?
Thanks, Dr. Gunjan. So the second question first, astigmatism, I go to about, maximum around 4.5. See, more than that, it's not about the accuracy, it's the regression. So patients develop regression more than that. So 4.5 is maybe the upper limit where you get a good predictable result. As far as patenting is concerned, see, I really wasn't too bothered about people copying it, because I can give it to free for whoever wants it. It's not something that I want to market or get kind of any monetary income or anything from that. It's just that I want to help improve the outcomes, and I don't think anyone is really interested in making something as tedious as this, because most people are already happy with LASIK results. And if say 2 out of 100 patients are going to have a refractive error post-op, they would do an enhancement and remove it. But for me, I really wanted that all patients, at least from my end, I should be able to treat them in the first sitting without having much of error. So that is why.
Yeah, but that's very good because really enhancements also have other related issues. So it's very good if you get one thing in a go and always to get a good result on the first day. So okay, so how would we get the software? That's the question.
Send me an email and I'll send it across to you.
All right, thanks. And what about, sorry, one more question. What about mixed astigmatism in your software? Does it work? Like mixed astigmatism works in your software?
All refractive errors.
Great. So we'll love to have the software with us.
Thank you.
Yeah, thank you, Dr. Zain. It was an excellent innovation, and all the question asked by Dr. Gunjan. But we want to share, and definitely we want the result of the good outcome. So if you can share, it will be very great for us, for the patient needed, and also we can have the study with the patients. It could be multiple place or in different place study. It could be a good outcome. Thank you very much.
I'll surely share it, Steve. Thank you.
Thank you, Zain. I think you can share it in the group as well, which we are part of. I think all the innovators here would definitely want to see and utilize the software.
Most important question, what is your email?
He'll put it as it, yeah, he'll put it in the group. Yeah. So thank you, Zain. So with that, we'll move to the fifth speaker of today. For want of time, we'll have the 15-minute discussion at the end. And the fifth speaker of the day would be Dr. Duong Diu Hong. So she's joining us all the way from Vietnam, who's having a novel Frontalis muscle flap surgical technique to correct traumatic ptosis. So from refractive surgery, we are moving into the field of orbit and oculoplasty. Over to you, Dr. Duong Di Hong, for your enlightening talk on how to manage traumatic ptosis.
Thank you, Dr. Prasanna. Thank you for inviting me here today. Today, I'd like to talk about frontalis muscular flap surgery to correct traumatic ptosis. I want to introduce two cases. Case number one, male, 19 years old. He had traffic accident 1 year ago, and he had no any systemic diseases. Ocular examination, best corrected visual acuity on both eyes is still good. Look at the picture. We can see he had dropsy on the left eyelid, and he had a scar extend from the middle of the forehead to eyebrow and left eyelid. The left eyelid crease is not clear. Their phenomenon is good in both eyes, no lagottomos, no diplopia, and tear breakup time test is normal in both eyes too. And the ptosis measurement in the left eye, the palpable visual height is 4 millimeter, MRD1 is 0, and the levator function is poor, 1 millimeter. Case 2, female, 52 years old. She had industrial accident 4 years ago, and she had done ptosis repair for 2 years. And on ocular examination, the visual acuity is still good. And look at the picture, we can see that she had dropsy on the left eyelid too, and she had a scar from the forehead to the middle of eyebrow and eyelid. The screen is absent, and their phenomenon is good in both eyes. No lagottomos, no diplopia, and TBUT test is normal. The ptosis measurement on the left eyes is palpable visual height is 2 millimeter, MRD1 is -4 millimeter, and the levator function is very poor, 0. As we know, traumatic ptosis occurs due to direct or indirect trauma to levator muscle. penetrating injury involving the levator can be repaired immediately. However, due to blunt trauma may resolve spontaneously over time. While frontalis sling surgery remains the gold standard for ptosis repair with poor levator function, the frontalis muscle flap surgery has gained popularity in recent years. And so today we want to share our experience in using frontalis muscle flap in traumatic with poor levator function. The anatomy of frontalis muscle is a flat muscle. Is cover the frontal bone and extended from cranial aponeurosis to skin of the eyebrows. And this muscle elevates eyebrow and wrinkles skin of the forehead. Blood supply for this muscle from branches both internal and external carotid arteries, and is innervated by the temporal nerve. And this is our technique on two patients was performed under local anesthesia. The eyelid screen is marked and is signed by a fitting blade. And next, a preceptor dissection is carried superiorly in a subavicularis muscle to approximately 1 millimeter above the superior orbital rim. And then we identify the frontalis muscle and develop the frontalis flap. We create a retarsal pocket for frontalis advancement. Then we the frontalis flap is affixed to the superior 1/3 of the tarsus with two proline horizontal matrix suture. And finally, we assess the lid height, crease, and contour compared to the normal eyes. And the skin is closed by interrupted 7 nylon suture. And this is the reason of case number 1. Look at the picture. You can see after 1 week, the left eyelid saw my swelling, the lid height, crease, and contour becoming symmetrical with the right eye. This result remained stable at 1 month and 3 months. And as the last visit, he had my dry eye, no entropion, and he was satisfied with the results. Case 2. After 1 week, she had significantly swollen on the left eye, and the eyelid, the lid height, crease, and contour were asymmetrical with the right eye. However, after 1 month, the swellness is reduced and the lid height is wider. And as the last visited, the lid height, crease, and contour were symmetrical with the right eye, and she also were happy with her result too. In discussion, the frontalis muscle flap to treat severe traumatic eyelid ptosis is effective and stable, and this technique has some advantages, such as eliminating the need for alloplastic or autologous tissue, less foreign body reaction, minimal ptosis, preservation of eyelid contour. Besides, it has some disadvantages, like it's a hard technique. Sometimes eyebrow asymmetry, reduce eyelid occlusion, more logotomal, and sometimes we can see over or under correction. In conclusion, our frontalis muscle flap advancement is not only effective in severe congenital ptosis, but also in severe traumatic ptosis. And this technique is advantageous in countries with limited material resources. Thank you.
Thank you, Dr. Dong. I would like to invite the panel for questions. Rolika, do you have any questions for Dr. Dong on corrective doses? So Dr. Dong, I just wanted to ask this question. So how long follow-up do you have among the cases that you were showing us? And I mean, how are the results spread out with other Asia Pacific countries? Is there any other people data that you have that you can share us few insights on?
We chose the 3K and because it's not much patient with the traumatic ptosis in my country, so we just have 3K experience, and with 2K is we successful, but one is a fail, so we will wait for maybe 2 months. We will repair it again.
So do you advocate this technique only for traumatic ptosis, or do you also advocate this technique for the other ptosis as well?
Yes, we use this in a poor liver function in congenital ptosis too.
How is the results in the other spectrum of ptosis apart from traumatic ptosis, congenital, even in senile ptosis? Do you have any experience using this technique?
For congenital, we just did this for 5 cases, and all of the cases is successful too, and we will wait for a long time for the best result.
Okay. Thank you, Dr. Dong, for sharing us your data and your experience on this particular novel technique. And so that brings us to the last but not the least speaker of the day. So we had an entire plethora of aphakic management, cataract, glaucoma, retina, then refractive and orbit and oculoplasty. So we have saved the best for the last with a teaching pedagogical model, one innovated by Arvind, Team Arvind here, which is the flipped classroom model, which is, they call it the new age pedagogy for young ophthalmologists. So over to you, Dr. Samir, who's also an executive member of YOSI, to enlighten us on this particular flipped classroom model. Over to you, sir.
Thank you so much, sir. A very good evening to one and all. So at the very outset, I would like to thank AIOS and YOSI for giving me this lovely opportunity. So in this talk, I'll be talking about presenting about a very unique teaching method. So I have nil financial disclosures. So all of us will agree that at some point in our life, we would have come across a teacher who would have deeply affected us in some in a positive way. And most of us will be familiar with this movie where a dyslexic kid encounters a really passionate teacher and completely transforms his life and rescues from his struggles. So teachers and teaching play a very pivotal role in all our lives. And in this presentation, I'll be talking about a very unique teaching method, which is the flipped classroom method. So considering the several recent advances and in the teaching tools and the resources available, rather than asking what to teach, the more important question is how to teach. And considering even the at the national level, the governments have been training teachers in different training methods. So considering all this, the traditional teaching method comes into question whether it is still good enough to stand to the current educational needs. So the traditional teaching method, it is more of teacher centric, and the educational content and the material is delivered in a lecture based instruction. Students are often clueless about the sources to refer and hence often come unprepared, which further decreases their understanding during the class. And hence, and also since there is not much of engagement or participation during the class, it creates a passive learning environment. On the contrary, if you see the flipped classroom method, the sources are provided and the material are provided beforehand the class, and the students come prepared, which further increases the understanding, and also the students are engaged to apply the concepts and the knowledge that they have learned before the class during it through various methods, which I'll be discussing. So this creates an environment for active learning and active recall, which has been scientifically proven to be a better learning way. So if you see the flipped classroom method, it basically has 3 levels. The first one is priming, the second one is participation, and the third one is produce. So coming to priming, it occurs before the class where the maximum efforts are taken by the teachers and the students. The material is provided, which might be a section of a textbook or videos on various platforms or even research articles. In certain scenarios, we might provide them with multiple options, which is referred to as cafeteria approach. Now, participation is basically which occurs during the class where the students are encouraged to apply their knowledge and the concepts which they have learned before the class. It can occur through various case scenarios. For example, a 26-year-old male who comes with certain findings and history. What would be your diagnosis, next line of management, or it could be through debates. For example, intravitreal triamcinolone versus anti-VEGFs for diabetic macular edema. And also quizzes can be conducted through various platforms such as Kahoot or Mentimeter. So all these methods ensure engagement in various forms. Coming to level 3, which is produce. So after the class, the students go back and they revise whatever they have learned before and during the class, and also refer to other sources. So this extends their learning and understanding. So let's see how we do the flipped classroom model at Arvind Eye Care system. So the lecture schedule is provided, the monthly lecture schedule is provided to the students beforehand. And if you see the DigiNof session, the one which has been outlined, the topic and the video has been provided to the students, and the coordinators are responsible for organizing the class and also preparing the quiz. A moderator who is expert in the particular topic is invited, who further facilitates the learning. So here you can see the student is preparing for the class by watching a video online. Now during the class, so we basically conduct a quiz during the class using the Kahoot app. So it basically you create a session and add multiple questions, and the students can log into this particular session using their cell phones.
It's the multiple choice question. Another following, all of the statements are true except A, myelination starts around 36 weeks of gestation. B, fixates starts by 3 months. Binocular fusion is developed early on 3 months. Pupil light reaction is present by 34th week of gestation.
So here you can see the students are recording their answer. So once all the answers are recorded, the correct option is displayed.
3 months. All the other statements are false. What's the correct answer? What are the other? Animation starts around 33 months. Next, Barnaculums developed around 2 months. Okay. And pupil light reaction is around 29 months. 29 to 30 months.
So this was a first year resident who was probably just 10 to 15 days into ophthalmology, and you can see how confidently she's answering the questions. It's possible just because the correct material was provided to her and she came prepared for the class.
Okay.
And we also display a live scoreboard, which also gamifies the session and makes it more interesting.
What happens to the corneal thickness? Is the corneal thickness more at the less at the area? It's usually thicker, and then it's the other side.
So the pupil light reaction is present by 30th week of gestation. Accommodation.
So explanation for all the options is provided towards the end.
That's why if you mother brings very often it happens. The mother brings a 1-month-old child or a 2 weeks old child and brings to you saying the eyes are squinting. So we need not actually worry. You should reassure the mother that the fusion will start to develop around 2 months. And actually, by not still you can.
So here you see the moderator is further adding to whatever was there in the videos, providing with supplementary information and also applying the theoretical knowledge to clinical scenarios. So after the class, the student goes back, revisits the videos, rewatches it, and revises whatever was taught or whatever he learned before and also during the class. He adds to his notes and also refers to other sources such as textbooks and various articles. So to summarize, before the class, the students prepare using high quality online and offline teaching resources. During the class, the students practice application of key concepts, and afterwards they check their understanding and extend their learning. So to conclude, flipped classroom method is a highly effective teaching method which is interesting and engaging with creating an environment for active learning and provides more comprehensive knowledge. So teachers can change lives with just the right mix of chalk and challenges. And these two have been very great teachers who have mentored me throughout my years in ophthalmology, and I'm very grateful to them. And once again, thank you for the lovely opportunity.
Thank you, Dr. Samir. Next, I would like to call upon Dr. Sonal Kalia ma'am, who is the Associate Professor of Ophthalmology at SMS Medical College, Jaipur, who's also a fantastic teacher, to add her comments on this flipped classroom model. Over to you, ma'am.
Thank you so much, Dr. Prasanna, for the kind introduction again. Dr. Samir, your talk was excellent, and you've demonstrated how even the first year residents are learning so much more. And to just my comment would be regarding now that even the National Medical Council has changed the way of teaching. They want us to go with the CBME pattern of teaching, even for PGs. Initially the traditional learning has been input based, but now the stress is on outcome based teaching, and they want us to create lifelong learners by using methodologies like 1 minute preceptor, SNAP, self-directed learning, DOAP, and there's most emphasis on that directly observed teaching, and how this flipped classroom is also very helpful, has been demonstrated, and ATCOM, attitude, ethics, and communication. So all this is also being implemented by the CBME pattern, which is the competency-based medical education. And it is a very useful way of teaching both at the undergraduate and much more useful at the postgraduate level. So excellent talk, Dr. Samir, and we look forward to implementing it all over the country in future.
Thank you, ma'am.
Samir, I have a doubt. So how different is this from the Kahoot model? I mean, do you advocate even is that an amalgamation of this flipped classroom technique, or is it a standalone one? What is your take on it?
So basically, sir, we are using Kahoot app only. So it's a paid version. The institution has got it for a 4,000 INR monthly subscription. So for all majority of the classes, for all the classes, we are using Kahoot app only.
Is this possible with any other application except Kahoot, or what do you advocate or recommend?
So there is another. So actually, you can do it with PowerPoint as well, sir. So
Okay.
beforehand, we used to use remotes which were connected via Bluetooth to a dongle. You have to invest in that, and we used to have PowerPoints. We used to create PowerPoints for that. The thing was, we could not make out who was scores and all. We were not able to get out of that. So who is answering the correct answers, incorrect answers, and all those things. Another platform is Mentimeter, which is also sort of PowerPoint based only, but it's online.
Dr. Aditya, your comments on the talk by Dr. Samir, or we can once you are done, we can open the panel for a 15-minute discussion.
No, Sabir, amazing as usual. Simple innovations making a lot of difference. And I think you're ready for student of the year 3 now. And great. I think overall amazing. Keep up the good work.
Thank you, sir.
Thank you. So with that, we'll move to a quick panel discussion again. I would like all the speakers and the panel available to please switch on your camera. And so welcome, Dr. Kendrick again. So Kendrick, your take on innovations as a whole and how a young ophthalmologist should approach innovations as a mindset. What is the mindset, or what is your take on it as a whole? Yes, Dr.
Yeah,
Ketan.
thank you. Yeah, thank you, Dr. Prasanna. I thought the talks were fantastic. I think it shows a lot of our young ophthalmologists are looking for unmet needs.
Yeah.
So be it in education, patient care that we're seeing in everyday practice, or also some of the things that we hope that we can do better, and we can look for solutions for that. Oftentimes, a lot of these things, there are still a very good idea to look at, conferences such as this, look at the literature, find out what's going on. Also, attend conferences. Innovation really is one thing, and you have to be very well versed with what is going on inside and what are some of the needs. And I think finally, to take the leap of faith to go and try something and be bold and to try to make it happen. If it fails, you still learn something from that. So I think that's what it's presenting this. They're not afraid to try something new for the betterment of patients and also medical.
Excellent.
And just to add upon the point that Dr. Gunjan has brought out regarding innovations, so it could be a simple idea, but how are we going to bring it to fruition is one, to make it a very practical and innovation that can be followed by all. And then how about the panel's opinion on the regarding of patenting it? So Dr. Aditya, Dr. Ashraf sir, I mean, what is your take on patenting? Zain did share his views on making it open access.
So I
it's
think
very
Zen is being very noble when he says that it's open to everybody, but still then I think you need to patent it, otherwise somebody will take it, patent it, and then sell it. So it's pretty much it's absolutely opposite. But I feel patenting is become a must. There are various degrees of patenting also. You can do it in your district, you can do it in your nation, then you can do it internationally, and of course the cost goes up. But any innovation, if you see fruition, I think you should patent it. Because in today's age, everything is so easily available online, lectures available, your ideas available. And when you're making your innovation a success, you sometimes over-explain, and that leads to easy copyright issues later on. So might as well go ahead and do it as a preventive measure.
Just to add on to what Aditya said, Dr. Zain, so I also believe in patenting. So my journey towards patenting started in 2021. It's still a patent pending innovation of mine, but I have filed the patent and it has come to hearing in this year. So it's almost been a 4-year journey, but I strongly believe, I also believe in your principles of giving it, for the benefit of teaching. I believe it in giving it for free of cost, but at the same time, we patenting it and then making sure it reaches the market will have a better hold rather than just leaving it without patenting. But let's see what the panel also has to say. Ashraf sir, your take, Dr. Chris, and even Zain, you can also share your views.
Yeah, definitely. I'm very much agreed with Dr. Prasanna and Dr. Aditya, because definitely it should be accessible for teaching purpose. But for nowadays, the communication and everything is available. But the person who invented it, the innovation, it should be patented, definitely, and it should be patented. And also, we should take care of that. It could reach to everyone for the education and learning purpose and for the better user purpose. Thank you.
Dr. Chris, your take on innovative procedures, which you showed a good video assisted skill transfer course that you really showed us. What is your take on these aspects of innovations?
Yeah, I think definitely need to patent these things. So even if you want to make it available for everyone, at least then it is at your own sort of will to make that free to everyone, as opposed to someone taking your and then doing something else with it. So I think it is very important aspect, even though it is a lot of work, like you have said, Prasanna, it is worthwhile going upon that journey to make sure then you can do whatever you want with it yourself, rather than letting someone else doing something with it.
And a lot of times, your own innovation may not be, original work completely. It may be just, the idea comes from some app, like you said, Samir, that you saw an app and then that triggered you to modify it. So that's also fine. So if you're within the patented laws, you can go ahead with the same idea and perfect it better with a new. Classic example is Facebook or Instagram. They're not the first ones to start social media. So we had many more before them, and they just perfected it and it became much more profitable.
Yeah. So coming to the teaching aspect of the innovations, Sam, I think Dr. Pranesh has been, one of the fantastic innovative teachers that YOSI has produced, and he has really been around YOSI for the last 4 5 years. We had the opportunity to listen to his talks and the wisdom of listening to the flipped classrooms. Have you done any original article or original studies between multiple centers, to see how it really impairs cognitive learning, or what has it really brought out in the community of students? So that, and what are the challenges that you would want to say if any teaching module would want to, bring it into practice? Like maybe in Tiruchi or Jaipur, or anybody who wants to bring it in any particular practice, what are the challenges that you see going forward?
So, answering your first question, sir, like as of now, we haven't studied the outcome. Like at our center, we haven't evaluated it, compared it with the traditional teaching method. But probably, yeah, we can take it up and discuss it. And probably the challenges would be, I feel would be it actually takes a lot of effort to prepare the session. So I don't think it's if you take any small, even for a small institution, I think it would be possible, because you just probably require a PowerPoint. So even with a PowerPoint, you can actually create a quiz, or even have a debate or whatever. You just have to provide the material. You just share the research article or the textbook or videos, whatever, through WhatsApp to your students. The challenge is actually preparing for the class, both from the teacher's part as well as for the students. So students should also be diligent enough to, come prepared for the class, and also to prepare the quiz or the debate or whatever it is. It actually takes a lot of effort.
I think, Sam, a lot of AI will be used in the future on this same, because it'll make this tedious process less tedious. So it could be interactions from students asking them they want to cover these aspects, and then the AI picks up and the teachers modify. So that will
I
make
want
that part
to
easy.
say that the biggest challenge for implementing this kind of a model across, many institutions would perhaps be the mindset change. So changing mindsets is what is difficult. People are, in their comfort zone where there's a traditional model of teaching, and when you introduce something new, it takes a lot of time to be accepted, and more so, I should say, at the teacher level than at the student level. Students may still want to, because they are new to the field. If you tell them that this is how teaching will be happening, they will take it up. But the senior leadership in various institutions, whether they would be open to immediately, taking it up, it will be a very slow uphill thing to be changing mindset. So at the end of the day, the biggest challenge that I see for implementing this as a norm, as a novelty, yes. If it has to be done once in a month, it's different. But if it has to be done as a norm on a regular basis, like you've demonstrated, then it has to be a change in the mindset. That is the biggest challenge that I see.
Also, what Sonal ma'am is also telling is, like, I feel like it also requires a lot of practice. So, like we have also evolved over multiple classes, over multiple sessions. It's not like we cracked it in our first class itself. So, what type of questions, at what difficulty we want to set, how we should organize. So, all these things were evolved slowly. What sources we should refer to. So we have evolved over, like, I think for the past 2 years, 1 or 2 years, we are having this flipped classroom model. And I think it has been a great success. But yeah, we have evolved through multiple sessions. And obviously, it requires a lot of practice to execute it properly.
Speaking about AI, Zain, can you hear me? Are you there? Yeah. So, Zain, how do you see the software that you have made? I mean, the updates going forward, any AI-based algorithms that you can develop going forward for the same?
So I'll tell you something very interesting. Only with respect to my software, Contura LASIK is what came out in 2016 by Alcon, and they have kind of understood that there were some problems with it and have recently rectified it by getting something called as Wavelight Plus. Okay, so Wavelight Plus is exactly what I was trying to do for so many years. That is, they understood that you can't just see the anterior surface of the cornea. So now they have a machine which is seeing the inside of the eye and getting how much of refraction is coming from the inside of the eye, and also incorporated AI into it. No question about it. See, AI is very useful. I don't think my software is going to require any AI because Alcon has come up with it now. So they've come up with a, fully marketed thing. Only thing is that it's kind of, it's right now really expensive. So with all companies moving towards lenticule-based refractive surgery, Alcon has not gone that side, and they've instead gone back to LASIK and come up with a better version of LASIK. So I don't know how the cost is going to play a role and make this technology taking forward, but Alcon has rectified the drawbacks using AI with the new software that they've got.
Thank you, Zain. Dr. Dong, we did have a lot of spectrum of traumatic ptosis surgeries that you really shared on. Can you throw us some more light on what are the other, the novelty that is coming in terms of trauma and orbit and oculoplasty for the young ophthalmologists who are listening to us in terms of innovations or novel procedures?
Yeah. Yes. Can you ask me your question again? I can't hear clearly. Yeah.
So as you showed us a lot of your data on managing traumatic ptosis in a novel way, what are the other things that a young ophthalmologist can really, throw his mind around on the procedures that are there, and what are the other things that you can say for a young ophthalmologist in this forum?
Yes. For the traumatic ptosis, I think this technique is very hard, and we have done a lot of another techniques. So if we want to do this technique, we just need to be care dissect it correctly in a suborbicularis plane to go the frontalis muscle, and in when we come to the frontalis muscle, we should be care dissect in the subcutaneous, and to avoid creating a buttonhole. In this step, this will be the hard difficult for the procedure. So we should be practice every day to do exactly for these techniques.
So yeah, so thank you, Dr. Dong. So we did also cover retina as well. Dr. Mia, are you there with us? Okay, so that brings us, to a wonderful session that we had in the last 1.5 hours or so. So we move on to the next agenda, which is the summary. So before we move to the presidential vote of thanks, I would like to summarize the session. And this has been a one of its kind session. We had a Young Innovators Forum by YOSI for AO's International Ophthalmic Conclave. The highlights were the 6 innovations A to Z. So you name it, novel aphakia management or glaucoma, congenital glaucoma tool assessment, innovative tool. We had a OCTA and its innovative role, which is coming up in retina, a self-built refractive software journey by Zain, and an innovative traumatic ptosis correction surgery, and finally a classroom teaching module. So we made sure we had 6 innovations A to Z coverage, and we were lucky to have 5 different countries here. So we would like to extend our thanks to Bangladesh, Hong Kong, Australia, Burma, and Vietnam. Thank you guys for taking time despite the different time zones, for being part of this wonderful session by AOS, where we YOSI had this opportunity to conduct the innovative platform. And the wonderful discussion on patenting innovations was brought to light, and how to bring innovative ideas to fruition And finally, the video assisted skill transfer of all was really a wonderful treat to watch, with a panel discussion taking it forward to the next level. So with that, we come to the last agenda of today, that is the vote of thanks. So I would like to call upon Devakant Mishra sir, our President YOSI, once again, to have the vote of thanks followed by a closing remark, which will end by a photograph. So please do switch on your camera. Over to the President YOSI.
Thank you so much, Prasanna. I really love how systematic you are. So, so thank you everybody for being part of this. And again, all thanks to AIOS, our parent society, the leadership of AIOS, especially Dr. Santosh Onawar sir, for giving us this opportunity. And our moderator for the day, Dr. Prasanna, for sticking to the time and managing the session and curating it so well. Dr. Gunjan in helping her out. And our panelists, Dr. Aditya, Dr. Ashraful, Karan, Dr. Kendrick, and our immediate past president, Dr. Sonal Kalia. Thank you everybody for taking out time. And we had such a beautiful presentations by everybody, and they were all very important, and it inspires us to work on new things and develop new ideas into products which can be used by all of us. So I thank Dr. Christopher, Dr. Karthikeyan, Dr. So, Dr. Zan, Dr. Wong, Samir, Dr. Prasanna, and everybody else for their nice presentation. So let's thank you all. Hope to see you all again soon.
Yes, sir. Thank you, sir. We'll end the session with a mandatory your photograph, if all may. Yes. 3, 2, 1. Cheers. One more take. We'll have one more. We are joined by Rolika as well. Thank you, Rolika. One more. 3, 2, 1. Cheers. Right. Thank you. Thank you all. So